afternoon, everyone. Thank you for coming to join us today for a very special seminar series by one of our very own, Dr. Vikram Aggarwal. Before I begin the introduction, I would like to make an announcement about next week's medical grand rounds next Tuesday morning. For those of you who wake up early and I would like to come in person, is a very special Chicago Scholar Lectureship. It's by Peter Hotez, who is very famous. And in fact, there's going to be a crew from one of the local news stations. It's going to tape his presentation. And the topic of the presentation is global vaccinations and anti-poverty vaccines, science versus anti-science. So Dr. Hotez is actually very famous outside of medicine. He's often interviewed on this topic, and Dr. Susan Quaggan wanted to make sure that everyone here woke up early next Tuesday morning and attended medical grand round. So if you can do that, that would be great. She especially thought this would be a useful opportunity for our fellows to come and get breakfast, just hot breakfast, but also listen to this amazing speaker. So if you can mark your calendar, 7:30, April 16th. It's in the Feinberg Pavilion Conference Room A, where medical grand rounds usually takes place. If you don't know where to go, Sherida, one of our first-year fellows, usually goes to medical grand rounds, so she can show you. So you can ask her to guide you. Okay, so that's the special announcement. And then the introduction today, most of you know Dr. Aggarwal, but for me, when I think of Dr. Aggarwal, I think ambition. Okay, that's what the first word that comes to mind. And sometimes ambition has a negative connotation, right? You're kind of so ambitious, you're getting ahead of the people around you. But today I would like to think of it as a positive connotation. And in that vein, there are two things that you could think about. One is recently our dean was interviewed by Sibel Gossain, Dr. Sibel Gossain, and she asked him a number of questions, and one question was about just sort of his view on academic medicine. And in that response, he basically said, in this setting, you need ambition, you need to overreach, you need to aspire and inspire, because otherwise we sort of be stuck with where we are and we wouldn't move forward. And Vikram certainly is not somebody who's been stuck. He trained in medicine and nephrology, first in India in Mumbai University, then repeated his training in the US and Canada, and was first an assistant professor at SUNY Upstate Medical University at Syracuse, and then moved to Northwestern, where he rose through the ranks and now has a leadership position as the medical director of our peritoneal dialysis and home hemo program. And he's a very successful educator. He received 2 awards from our fellows within the last 3 years. So he's very well known for sort of teaching our fellows about both peritoneal dialysis and home dialysis. But today we're going to hear about his other kind of frontier, and that's onconephrology. And within this onconephrology territory, there's a story that also reminds me of ambition. A few years ago, Vikram had a patient who had a liver cancer and had hypophosphatemia that people were trying to figure out, why does this patient with liver cancer have hypophosphatemia? And some of you might know that we have basic scientists who work on fibroblast growth factor 23, and sometimes there is this type of tumor-induced osteomyelation where the tumor makes FGF23. And he went to these basic scientists and asked them to stain the tumor for FGF23, and actually was able to do it, and had a presentation at ASN about this. So anyway, definitely someone who's ambitious and who is leading us forward in multiple areas. And today we'll hear about onconephrology. Thank you very much, Vikram.
Hi, thank you, Dr. Isakova, and thank you everyone for joining. I'll start with a little bit of how this journey started. So, of course, I trained twice for everything in nephrology. And during that journey, I was very excited about the immunology of nephrology, like, how the immune systems interact. And during this journey, I always felt the field of oncology was very intriguing and was very, or even hematology was very intriguing. So both oncology and hematology, you cannot take them away. And both are have a great intersection, unfortunately, and even fortunately, to learn from each other and help patients further. Um, and why I just choose, and I was actually going back and forth with individualized care or subspecialty. But as clinicians, all of you who are practicing nephrology come across patients who have cancer. So we know how common it is to have cancer and kidney disease. And when those happen, we see them and we try to provide best care to them. But then it has slowly evolved into a subspecialty by itself. And now we are gathering more and more evidence, because before it was more like case reports. But over the last 7 to 8 years or 10 years, there is like a Society of Onconephrology. There is a lot of attention at ASN, ISN, and KF. So it's in itself a subspecialty, and some centers offer onconephrology fellowship, at least 3 of them, dedicated 1 year. But then, a lot of that we started to do here at Northwestern. And then in the end, I still go back and think that we have to still individualize therapy, because here it is another disease involved. It's just not kidney disease, but oncology. So things change every day. So applying protocols or templates or evidence sometimes is not possible. There's a lot of discussions happening. So it is in the end a combination of applying evidence-based medicine and still continue to individualize care. So I will. Okay. So I'll start with my Northwestern experience of when I moved here, joined as a junior faculty. I was, as Dr. Isakova said, ambitious. And I was like, okay, I want to do something here. So I reached out to Dr. Gradishar, Dr. Hakwan, and Dr. Mulcahy. They were the leaders. They are still leaders in oncology. And I, with the help of Dr. Quag and Dr. Gosain, I attended their business meeting and proposed that we want to start a program. And when I went to them, a lot of them said, we already have great nephrologists. And I said, fantastic. Yeah, we have great nephrologists. But how about I give you access? I give you 2 clinic days. I'm on call 24/7. These patients, I want to avoid hospitalization. I want to give them clinical care. So, and then it just evolved. I gave them some referral diagnosis and also some flyers. So it all started with their 1 patient, 2 patient. In the beginning, it was all about electrolyte disorders, because that's where we all are more nervous about, like the primary care or the oncologist is hyponatremia. So that's what I saw in the beginning. And things, as you know, that cancer field is evolving every day. The therapies are evolving every day. In the last 7, 8 years, I could see that the work has moved away from electrolyte to more of the checkpoint toxicity or targeted therapies, which is what needs more attention. So, and then I know we present this in the end, but actually today, uh, slot was supposed to be filled by Dr. Nelson Leong. He is a great inspirer, mentor for all of us in the field of onconephrology. He's at Mayo, and he's a great physician scientist, and he's like phone a friend. We all need that, especially in this area where we don't know much. We still want to be very evidence-based. And so is Dr. Jonathan Hogan, who presented a grand round here in 2018 and really inspired me to um, practice onconephrology. And then I cannot take away our oncologists. Some of them are on the Zoom call. Thank you for joining. And big on that team is our nurse practitioners, APP in oncology, our clinic staff, who without them, there cannot be access to care. This prompt care that I am proposing cannot happen without our clinic staff. So all of them, and then of course, urologists, pathologists, all of them go together to provide great care to our cancer patients. And one more I want to start with is, this was when I was just came out of fellowship in 2007, 2008 in India. That is the time I was appointed to go to a cancer hospital in Bombay, India. And that's when I was asked to organize a conference on monoclonal gammopathy and kidney disease. And you will see one name here. Some of you know Dr. Singhal, who is one of the pioneers in myeloma. At that time, I had sent her emails to invite her. I did not know that I'm going to work with her. But back then, we were already thinking of how does MGUS impact kidneys, or like we didn't coin the word monoclonal gammopathy of renal significance back then, but this is what a flyer I always saved is like, so, and now it has evolved again as a subspecialty. So today objectives are to, again, these are all objectives are covered in the various slides, but it's very hard and beyond scope of today to discuss all the disorders which an onconephrologist or nephrologist face regarding kidneys. So I'll give you more of like the pearls that I've learned or the evidence that has been accumulated, where we can be a little confident in practicing or giving best advice to oncologists. And then again, I want to just keep on sharing at the same time that even though this evidence is there or science is there, we are always individualizing because the patient is an important stakeholder here. He or she is going to infusions, going and suffering from symptoms. So I think we just keep on reminding, and that's become more and more of my work, is talking to the patient, hearing, and just one size does not fit all. So cancer is a journey. Um, right from the diagnosis, and more so now, it's become a bigger and longer and successful journey is because we have a lot of cancer survival. The treatments are excellent and getting better and better every day. And that kind of prolongs the journey in a good way. The more targeted therapies, the more immunotherapies, are taking that side effect away. So journey is getting better and longer. But with this journey, uh, we still stick to the principles. And principles are at the time of diagnosis, which still is needed, is timely detection and access to optimal care. While we are doing this, just keep in mind that almost the same things we are doing in kidney disease or chronic kidney disease. We are still in need of timely detection and access to optimal care. But so there are a lot of comparisons I always make between oncology and chronic kidney disease or nephrology, where early disease is GO, CKD, 1 to 3 is early detection treatment, late is to manage with dialysis or transplant. So let's just focus early stage. What does the oncologist and the patients decide to do? Is to go for curative therapy that entails surgery, chemotherapy, typically 2 to 3 drugs, radiation, which is high dose, depending on the type of cancer. Immunotherapy and targeted therapy have really changed the paradigm now. And then what is more interesting is the late stage cancer or the palliative approach. It's not just the palliative approach, it actually is very good cancer free, or even with cancer, there is very good survival, and which involves uh, offering chemotherapy, low dose, 1 to 2 drugs, radiation, low dose, immunotherapy, and targeted therapy. These have really offered a lot of hope and have a lot of scope in late stage or what we call stage 3, stage 4 for most of the cancers. But while these are happening, what oncologists actually are doing, and they have a big team. Trust me, we as chronic kidney disease doctors, we and the patient. But in oncology, there is a lot of discussion happening between risk and benefits. what are the risks, and that they are supported by a huge team. I was surprised, like you go to oncology offices, when I go there, they have these huge support nurses, nurse practitioners, social worker, and a lot of support system to keep on maximizing patients' experience. So when we talk about curative therapy, we're talking about benefits because it has to make sense to the patient. What are we trying to do? So there, oncologist is trying to increase the cure rates, but at the same time talk about side effects, toxicities due to drugs or surgery. And then, well, that seems to be a little hopeful, promising. But when it comes to palliative approach, we're still not giving up. We want to still focus on their symptoms, increase their survival duration. And that's what matters to the patient. At the same time, we talk about, okay, we have some things to offer which are good, but there could be inconvenience related to the drug toxicity. So this is all, it's getting better and better. So I told you that Dr. Battier will like this, the soccer field here. So I was thinking about like what we have done and how we all as team are performing here. So I said, cancer is a journey. It is also a team sport. So let me explain. I just made this up. Is so we are trying to. What is missing here is the football, or it's not actually football. It's the patient. Very important person here. But we are trying to address the goal. Goal is to cure cancer. So towards that, upper side is the goal to cure cancer. And in that is involved a medical oncology team, surgical oncology team, pharmacists, radiologists, many, many more. So we're trying to move the patient towards the goal of cancer cure. But as I said, when there are benefits, but there's always we have to fall back. We need defense. And where I see us as other subspecialty, which is nephrology, hospital medicine, cardiology, dermatology, we all like defense mechanisms where we are trying to still have patient reach their goal. If all goes well, we move and score positive goals. We fall back if there is palliative care needed. And that's when we still do a good job. And so it's a team sport. Without that, cancer patients will be not achieving what they want. So we'll move our attention to how oncology and nephrology kind of come together. And why I said A, B, C is it's just not oncology and nephrology. We have other members of the team, radiologist, urologist. It's all constant talking amongst each other. It's just unfortunately not just CKD. It's just a lot of talking happening because drugs are changing, things are happening there. So to give you a spectrum of what happens when a cancer patient has kidney issues, typically an oncologist will refer to a nephrologist for um, pre-existing CKD, acute kidney injury, fluid electrolyte problem, hypertension, proteinuria, acid-base disorders, or if there are patients on dialysis. Or a urology or oncology will communicate with us regarding urologic cancers and relative obstructive nephropathy. Sometimes we refer to the oncologist, and that is for what you have heard about when we evaluate a CKD patient with unexplained problems, and you feel like there could be a myeloma. We call it monoclonal gammopathy of renal significance. And that's when we send them and try to still enhance or improve their care. And also, while we are all following transplant patients, we know that a lot of our transplant patients are susceptible to cancer, so we refer them then. And I don't want to leave out our hematologists who are very important, and we need them often when we are needing therapeutic plasma exchange, or when we are managing thrombotic microangiopathies, or we are using B-cell therapies for managing glomerular disorders. And that's where oncologists have come to our rescue. Of course, we can use rheumatologists, but oncology or hematologists have helped at Northwestern a lot, tremendously. So this is the whole scope and how we intersect with each other. But let's move to how a cancer patient with renal issues, when we get consulted, these are some of the questions that they have. Some cancer patients might have a pre-existing CKD, or there is a confusion related to their GFR and how they do the dose calculations. Or could be a scenario which is very common is acute kidney injury in patients who have cancer, or it is related to a therapy that is being offered. Or there is evolution of chronic kidney disease in patients with cancer, obstructive uropathy, new onset hypertension, or management of pre-existing hypertension, proteinuria, or these patients are on dialysis. So, and you all can relate to these referrals. Coming to the plight of patients, cancer patients with pre-existing CKD. So this is a meta-analysis of 95 studies. So one thing is FDA is now insisting to all the cancer drug trials that there should be inclusion of chronic kidney disease. There should be, compared to the past, especially since 2015, there is more emphasis on including chronic kidney disease patients in offering in when drugs are offered in cancer care. And also to have a better understanding of pharmacokinetics. We need to do it more, more with evidence. So this is a study which or a meta-analysis looked at all these studies. And they did see inclusion of kidney criteria. But, and I just want to give you an idea about what are they using as GFR methods, because this is a field which is moving every day. So the gold standard is to measure GFR, which is with inulin or iothalamate. So that's like 8% are being through the gold standard, but otherwise 65% patients in most studies use a eGFR or estimated GFR. So pharmacokinetic analysis for these new drugs are being only studied in especially CKD4/5, which is where the problem is only being studied in 29% of the drugs, and 6% of the drugs we are studying pharmacokinetics in dialysis patients. And then there is no information regarding drug dosing in almost 50% of these drugs. So a lot of these patients are excluded, and hence they are being deprived of optimal cancer care. And the median GFR that was included was like they found that up to 45 or above was where things were happening for the drugs in kidney disease. So switching grounds to like the biggest dilemma for all of us, and we are moving is what is the best eGFR? We know that measuring the iothalamate or inulin is really cumbersome. So how do we, so there are a lot of initiatives taken to study either creatine-based or cystatin-based or combined. And by itself, just to give you an example, eGFR with creatinine has its drawbacks because of people with cancer might have sarcopenia. So it could be overestimation of GFR, or a lot of drugs kind of delay the excretion of creatinine, which we'll talk about. And cystatin, on the other hand, the corticosteroids do influence cystatin estimation. And so, and some of the cancers actually release cystatin, breast cancer, prostate. So combined cystatin and creatinine equations are actually being more and more systematically studied, or the EPI equations studied. There is enough data to say that cancer is higher, especially myeloma, and GU cancers are more in patients with kidney disease. Cancer survival is reduced in these patients, and rightly so, because if they are excluded from drug trials, they don't have access, we don't have optimal dosing, their survival will be impacted because we are not doing the right thing with their medications. Of course, these patients with pre-existing CKD have risk of AKI or progression of CKD. And a lot of these patients have the same kidney risk factors, diabetes, hypertension, and we need to do a good job. Often the patients get busy with oncology, getting their treatment, and these are go unattended to. So, so this journal, The Advances in Chronic Kidney Disease, has a very good one entire journal supplement dedicated to various onconephrology issues, and I really find that very helpful. So talking about AKI, which I don't need to talk, we talk about pre-renal, renal, post-renal, but just to give you a spectrum, in the first year of cancer diagnosis, the risk of AKI is about 20%. First 5 years, like up to 30%. And severe AKI requiring hospitalization or dialysis is up to 10%. And the etiologies could be, as you know, pre-renal, intrinsic, just to name thrombotic microangiopathy, glomerular diseases, paraproteinemic kidney disease, direct infiltration of lymphoma or leukemia into the kidneys. So that's your intrinsic component, in addition to the acute tubular necrosis or drug toxicities. So the drugs, chemotherapy, immunotherapy, stem cell transplant, even nephrectomy. So this is all treatment-related side effects. And then if that was not enough, hypercalcemia, tumor lysis. So the differentials are so broad here. And that becomes it more hard and challenging, which is why I feel like more and more experience helps you to optimize, because then otherwise it leads to a lot of hospital days in the, to manage this AKI. So we need to evolve. So in addition to these factors, um, it is also not uncommon that we have patients on, so this relates to the systemic. So of course the drugs lead to significant risk of acute kidney injury. Um, but in addition, a lot of these patients on ACE, ARB, diuretics, and these can also lead to temporary changes in their GFR. So keep in mind that it's not those very fancy diagnoses that we make. Common things common. These patients are on drugs which are ACE, diuretics, which could lead to AKI. So, and then I'll talk more about this, but I just want to touch on the common cancers which are talked in chronic kidney disease. So this is looking at risk of AKI. So bladder cancer, which is common, even though we say that these drugs are toxic, but the cancer itself is more, puts us more at risk for AKI. So bladder cancer can lead to obstruction. So if you look at the um, regimens, of course, cisplatin puts you at risk, but if done properly, it actually reduces the risk of AKI. Because if you don't treat that bladder cancer or GU cancer, it lead to obstruction and more risk of AKI. In myeloma, myeloma itself leads to kidney disease. So if you start patients of myeloma on some of these therapies, it actually reduces the risk of AKI versus letting myeloma cause AKI. But the highest risk of AKI in these hematological cancers is post hematopoietic stem cell transplant in leukemias and myelomas. So moving to just these very tough situations is something which is more simple. We read about creatinine secretion in the tubules. So my request is always is to, so this is a case scenario where the patient with breast cancer was referred to our clinic and started on this CDK inhibitor. And so was started on September 2021 with this baseline creatinine. And immediately after few months, you see the creatinine or the GFR started to look low. And then we went back. I was with, I think Ibrahim at that time, our fellow, and we're like, okay, let's do a cystatin. And the cystatin takes the GFR back to what it was before this drug. So, and then we, of course, looked back and we saw that this drug inhibits one of the secretory mechanism or pathways for creatinine. And since then, I have been keeping a list of all these drugs, mainly the targeted therapies. Uh, and you just keep in mind, always when you are dealing with the AKI or elevated creatinine for a cancer patient, always look up the drug up by its generic name, like the mechanism of action. Please, just not the drug, because then it'll take more clicks. First thing is go to whichever resource and find out what mechanism it is. And then you will, and I have kept on adding these drugs to my list so that, because otherwise response time, you will send 20 more tests rather than trying to only add one. You'll order ultrasound, kidney, myeloma testing, everything. But if you have this information with you, I just have saved it on my phone. So when I see that drug on that list, I was like, maybe I send a cystatin before I do a lot of testing. Actually, one of this was a case report a few months ago, one of these drugs in NEGM about just elaborating on, don't forget about pseudo AKI. Let's move just quickly about a conventional chemotherapy. We know back in the day, these were the drugs which had a broad mechanism of action, a lot of toxicities. And these, for example, are ifosfamide, methotrexate, pemetrexate, which we are using more, pemetrexate, cisplatin, cyclophosphamide, gemcitabine. These are still have their role in GU cancers, small cell lung cancers, very effective, but these can cause a spectrum of kidney injuries, including thrombotic microangiopathy, tubular injury, chronic kidney disease. These drugs, we have to be careful with the dosing. High dosing can cause problems. And uh, and so you often will be get consulted, nothing much except for supportive care for these patients. There's really no, um, except for you just say, probably this drug is causing it. It's hard to kind of get biopsies done in this patient. There is no one uh, pathologic finding. So doing a biopsy, I will not recommend because it's very heterogeneous, the biopsies are, but these are so very well associated with kidney injury that holding the drug and finding alternative therapies are better. I'll just talk a little bit more about methotrexate because literature is evolving there. So especially in the field of lymphoma and CNS lymphoma. So in CNS lymphoma, high dose methotrexate is a game changer. It really changes cancer symptoms, survival, everything. So this is where they need us the most. Methotrexate by itself will, for the first time or subsequent use, cause a creatinine elevation. We know that methotrexate crystallizes in the kidney, and these are not like one time. They at least need 5 to 6 doses of very high dose, every 3-week high dose methotrexate. And that's where actually the pharmacokinetics physiology comes into play. And just remember, and that's where I worked with our lymphoma experts to devise our own protocol of admitting patients before giving. So what we need to do is give a lot of fluids, have a good urinary flow, alkalinize the urine. We do that in the first 24 hours before admission, rather than keeping them forever in the hospital to deal with AKI. Give a lot of fluids, alkalinize the urine. And then what was being kept away was the use of glucocorticoids. You have heard about glucocorticoids, which actually cleaves the methotrexate whenever there is a toxicity. So when patient gets a methotrexate high dose, they watch their methotrexate levels very closely. They watch creatinine every day. And there is very high risk of this happening. But glucocorticoids is an enzyme that will cleave methotrexate and prevent further AKI or systemic methotrexate toxicity. So it's very expensive, not available readily. But we have now two good evidence. One is a meta-analysis, and other is a multi-center study done out of Mass General, which we contributed patients to. And glucarpidase is beneficial in the first 60 hours if you see a rise in methotrexate and worsening kidney function. It is helpful in reducing the risk of AKI or subsequent AKI and other extrarenal side effects. So please advocate for the patient, talk to the pharmacology and say there is enough evidence which is already there and building to use this drug. Moving to more targeted therapies, which is tyrosine kinases, VEGF inhibitors, um, more of the kinase inhibitors and epidermal growth factor. Not much. These are targeted, so they have very precise mechanism of action. And but they do cause subtle kidney problems, mainly like the kinase inhibitor, tyrosine kinase inhibitors and the VEGF inhibitors. I'm glad Dr. Quagin is here, who has really contributed and really helped this field. So proteinuria, hypertension, thrombotic microangiopathy, although thrombotic microangiopathy is very, very rare and renal limited, but more so is the hypertension, proteinuria, and probably some AKI. And that's where we get consulted a lot. Biopsying these patients really is not something which will help the patient meaningfully. I mean, not much classic biopsy findings that you can do much about, except for altering the dose of the medicine, moving to alternative targeted therapy. So just try to be careful in how much you investigate. I'm just giving you, as I said, just pearls, not discussing each and every, but I would like to VEGF and tyrosine kinase inhibitors, we get a lot of concerns. So VEGF inhibitors are the various kind of uh, the VEGF modulations. So the commonest thing common is proteinuria, hypertension. Proteinuria is still not well understood, but could be some of the podocyte effects. But what we see is the extreme cases are very rare. So first thing is, if hypertension happens, control that hypertension. Don't be, this is the drug which is a game changer for a patient. So don't be in rush to stop that medicine, please. So up to 2 or 3 drugs and a better, good blood pressure control, what you want, 130/80, 140/90, try to achieve that, okay? Proteinuria, up to 2 gram, continue. Use your drugs, ACE, ARB liberally, and don't try to take the patient off the drug. Of course, if you start seeing creatinine elevation, significant proteinuria, or then do biopsy, because you might unearth underlying renal limited TMA, and that's where you stop this drug. Short of that, try to manage how you would manage a CKD or a hypertension or a proteinuric kidney disease. But if proteinuria starts to go above 3, or a lot of these patients are actually sometimes proteinuric, but little hypotensive, I've seen. So even use of ACE inhibitors at night, like, small dose, some of these. But there's not much literature on what we are doing in this, like long-term. Coming to the biggest category is immunotherapy-related kidney injury. And that's really changed most of the consults. This has become the more common consult for us when we are in the hospital and even in the clinic. And that has now become almost 50% of the work in the clinic is checkpoint inhibitor. Is we are trying to build some evidence on this. Of course, then you about CAR-T therapies. Even though we talk about the risk of immune checkpoint inhibitor-related AKI is about 2 to 5%, but the utilization is so much that you see many of these cases compared to any other consult. So, and I'm glad that we could come together to support this multi-center study of looking at AKI in immune checkpoint inhibitor. There were 429 patients on checkpoint with AKI and without AKI as controls. And so the observation was that typically AKI develops at a median of 16 weeks after initiation. what also was an observation or association was that if somebody had CKD, use of PPI, extra renal or other immune-related adverse effects, these are the patients who have higher risk of AKI. So always use this. I mean, if you're looking to jump into biopsy, but if you're seeing some of these features, sometimes a lot of these patients have only one kidney. Checkpoint inhibitors are used in people with GU cancers and also even melanoma. Often these patients are not amenable to getting a biopsy. So some of these association can help, and then help with you giving a trial of, treatments which could help. And in this study, it was very obvious that the commonest lesion is acute interstitial nephritis. So before we were not sure, could it be a glomerular disorder? But common was AIN. And we know a little bit we had heard from our previous grand round speaker is like how AIN has evolved. And so steroid is an option. In addition, what this is trying to tell us here is that if steroids started early, in this, as per the observations from this, if steroids started early in these scenarios, renal recovery is better. So always a high index of suspicion, use your various associations and maybe a kidney biopsy and start steroid early, recovery will be earlier. Another recent, because these checkpoint inhibitors are just not in isolation. Patients are getting chemotherapy, other chemotherapies. It's 2 or 3 like simultaneous therapies they are getting. And in that, it becomes very hard when somebody is on pemetrexed, on checkpoint inhibitor, especially the small cell lung cancer patients, getting 2 or 3. Each and every one could be toxic. And when this was the meta-analysis looking, when they compared with use of chemotherapy versus addition of these checkpoints, they found that AKI was more in patients who had an add-on of PD-1 or PD ligand 1 or checkpoints in these patients. So these checkpoint inhibitors, in addition to chemotherapy, make them risk of AKI more. So kind of this helps me to, is like maybe you go for the treatment in some of this, because there could be a component. We know that some of these chemotherapies can cause chronic kidney disease, but if there is a recent start of checkpoints, then maybe consider a biopsy or steroids in this patient, empiric steroids. Again, it's more of an art than science, as I said in the beginning, that there are a lot of questions that the patient and unique questions that the patient or oncologist will have. What if the AKI happens? Should I continue the therapy? Steroids has its own side effects. Can we consider alternative therapies? Biopsy versus empiric management. Could we re-challenge? Because this drug has worked really good. And now we have this AKI, a deviation from the pathway. So, and often in the clinic, we're spending time in calling oncologist. It's just not one stop. It's an ongoing discussion going on. Things are changing, and I can see, you know, here some of the audience is nodding heads because they have been doing this also. So it's a lot of talking that goes on, even taking some of the discussions to tumor board. So it's a teamwork. I'm not saying that one size would fit all. So I can talk real quick, but we have unique kidney problems in patients who get hematopoietic stem cell transplant. Some of them being common is they are prone to sepsis, they get a lot of antibiotics. And in the first few days, it's more of the conventional pre-renal, intrinsic renal due to drugs. But as the patients make it for after 30 days, is we start seeing graft versus hope disease for those who get allogeneic bone marrow transplant. And then we start seeing chronic kidney disease, some of them. And then we see some patterns which have been associated, membranous nephropathy, which we still don't know why it happens, but at that time, even graft versus host disease is going on. So these are really some of the patterns that we have seen post um, bone marrow transplant. Again, why we have to discuss this is the incidence of AKI is very high and chronic kidney disease very high. CKD is up to 30%, and AKI more so in myeloablative allogenic, and even in non-myeloablative, the risk of AKI is quite up to 50%, and these patients also end up needing dialysis. The risk is very high here. I've discussed this. I often start refer to the International Myeloma Work Group. This is some important resource that you could have. They kind of come out with better recommendations every time about what practices we should be having. So in that, I think there is often a dilemma that when we are having a patient with myeloma, should we biopsy or not? And that's where it is not that straightforward. Not every patient of myeloma who has a kidney problem will have a myeloma associated kidney disease. If you have, or why should you be biopsying? Sometimes it's like, why do we biopsy these patients? But if you have a obvious, very high free light chain um, in the circulation, and you have selective proteinuria, by that I mean is that you have light chains in the urine, you have light chains, very high circulating light chains, then you know it is a myeloma causing kidney disease. And in those, the myeloma work group does not recommend a biopsy. Uh, and, and if there is non-selective, means you have albuminuria and your free light chain is not very high, you have albuminuria, which means there is renal filter problem. In this case, you suspect that there will be some myeloma associated glomerular disease or tubular disease. But if you don't have proteinuria and these patients have myeloma and have CKD, then do consider biopsy. There could be something else going on. So I'll just jump here. This was a very nice study or observation in China where they looked at almost 700 patients who had kidney biopsy in patients who had monoclonal gammopathy. And they found that the detection of MGRS lesions or lesions were more common in people who had free light chain ratio more than 5.6, patients who were older, and who had proteinuria more than 1.5 gram. So I think this is a subset of patients where you should consider doing a biopsy because you might find a monoclonal gammopathy of renal significance for which you can ask help of oncologist to treat it. So other than that, when we have myeloma and severe kidney dysfunction, always make sure that if it's a brand new diagnosis, patients benefit from use of steroids. Okay, so that is the recommendation by myeloma work group. Plasmapheresis, we have enough evidence, doesn't work. So this is a firm recommendation, good evidence now. We know that proteasome inhibitors are important. Of course, the oncologists are doing that, but have faith in them. If you have a patient starting with a kidney injury in the hospital, of course, cancer teams are on top, but you want to see that patients are getting dexamethasone, getting proteasome inhibitors. They are getting, in addition, immunomodulators like lenalidomide and daratumab, which is anti-CD38. Start getting used to these drugs, because these are standard of care. Okay, so well, the holy grail, like um, as I said, this is common, very common. But why I kept it in the last is, at least in my case, the practice has moved more to managing checkpoint and drugs toxicities. Maybe because is that you also want the entire oncology workforce to be confident. And some of these, actually, I have sent 1-page, 2-page recommendations for them, and they are managing it there. Nurse practitioners, APP, like hyponatremia, they are so much used to giving urea sodium now, or not they use tolvaptan, but urea sodium, chicken broth, more protein, some of the commonest things which prevents elimination of water or SIAD kind of conditions. Hypomagnesemia, we know it's some of the drugs can cause renal magnesium loss. So they order a fractional excretion of magnesium for me before a consult. And then they kind of also, because when it's overwhelming, sometimes it is so much that they require every week of magnesium infusion. Sometimes they calculate and they will put patients on amiloride, and then they'll and it has helped because those infusions could happen every day. Like they have tremendous magnesium loss. Um, Hypokalemia, I'm seeing more and more adrenal involvement due to checkpoints and VEGF inhibitors. So often fractional excretion of potassium, TTKG, amiloride again helps. I have had dialysis patients who I'll talk about that. Dialysis patients who have significant hypotension, and we say, oh, fluid, check their dry weight. But these patients' adrenal is knocked off with checkpoint inhibitors. So giving steroids. I have had these 3-4 scenarios. Hypophosphatemia, as Dr. Isakova talked about, the FGF23. So some of these are, and sorry, when we talk about adrenal insufficiency, I get a lot of consults for hyperkalemia and not so much hyponatremia in those cases. And usually, again, evaluating them for adrenal, that triggers adrenal insufficiency, and then giving them spironolactone, fludrocortisone to reverse the hyperkalemia. Some of these are like I have evolved in my thought process to take care because they still need to get chemotherapy and therapy, and these hyponatremia, hyperkalemia become a hurdle in getting them. So question comes up is management of hypercalcemia. So even up to a GFR of 30, you could use palmitonate 1 dose, but you got to treat that hypercalcemia. Otherwise, the hospital stay will become longer and longer. We have a lot of cancer survivors, the kids who underwent nephrectomy, bone marrow transplant, nephrotoxic drugs, a lot of cancer survivors with these drugs. The incidence of proteinuria or prevalence of proteinuria and chronic kidney disease is quite much in these patients. So after discussing all those case reports or all these, main thing is to individualize care. And what I learned is these patients are very busy with their infusions. COVID time was one which really made me like we were doing telemedicine. And now I'm just having my last half day for tele-onconephrology visit. So all I see is numbers. And even the initial consults, which if I know, because there's a lot of communication that has happened between the NPs, and so I felt like tele-onconephrology still gives a good quality of life. I mean, as long as things are easy. Of course, we need to provide access to the patient, to the oncologist, to the nurse practitioners. There needs to be a lot of shared decision. No one person is right. And that's what has happened over time is that between oncologists and nephrologists, we keep on talking with each other so much that there's no right or wrong answer sometimes, but just trying to help the patient. Of course, some of them progress to dialysis, discussions with what is more important. Is kidney more important or cancer more important? I mean, again, every patient might have theirs. Some patients are like, heck no, I don't want to be on dialysis. I'll stop this treatment. Some are like, I want to beat my cancer. I could be okay with dialysis. A lot of discussions happen. You call the oncologist, and these are very difficult discussion. So prioritize the patient. Then some of these disorders have a scientific basis. And these could be N of 1 or anecdotal, but we still could treat. Again, you might say I am a big fan of rituximab or these or 1-2, but I've seen that those work. If there is a basis for thrombotic microangiopathy or a minimal change disease or membranous, I have very selectively used these uh, whatever higher medicines, and these have helped. And in the end is support the journey. So I'll just say again, the journey of oncology patient is we see them in the hospital with AKI, CKD. We initiate a consult, but please follow them in the clinic. Um, Support their journey with balance of cancer and kidney outcomes. Don't be focused on kidney outcomes. Cancer outcomes are equally important. Uh, Also do manage hypertension, proteinuria, their symptoms, fluid electrolyte issues. Try to keep them. This keeps them from hospitalization. They are getting these cancer therapies as outpatient, but what takes them to the hospital is a lot of these renal issues. Try to kind of manage in the clinic. Also guide them with transition to dialysis. Once again, home dialysis is not bad. Actually, we have a lot of, being a tertiary or a high volume center, we have a lot of home dialysis or dialysis patient going through cancer treatment here because we are under one roof. And then keep on engaging with the oncologist. And for those who are eligible and got their cancer taken care of, please advocate for getting them a transplant. Don't stop there. So I will just, for the people who are fellows or really wanting to take this further, there's a lot of opportunity. I have learned a lot from Onconephrology WhatsApp group. This is a group. There are 500 nephrologists who are on that WhatsApp group. A lot of this data, I mean, it's easy to fall behind with the literature. For this presentation, I went back to 2 years of what I could get every evidence there. I don't have to screen through journals, like which one, because I also still want to give you evidence. Very selective, very high level evidence being shared there. Um, Journal of Onconephrology is evolving. There is American Society of Onconephrology Journal Club. I was talking to doctor. It's available for you, happens weekly basis. Okay. Uh, there is an annual Onconephrology symposium. Now there is this collaboration. They are having a library of these onco or nephrotoxic medications, and they are keeping a library of all the evidence in that. Of course, pursue Onconephrology fellowship, or all of our nephrologists and clinics have enough cases. Do pay attention to how they are being managed. I've learned a little bit on by participating in some of the observational red cap data entry studies, and that's how it helped me to learn more. And then within your organization, do participate, support your oncologist by forming these mini workforces to that will help you show that how passionate you are to provide nephrology care. And then just lastly, I'll just quickly screen through whatever work I've done with each and every oncologist. Here at Northwestern, we've treated successfully some proliferative glomerulonephritis with monoclonal deposits in the kidney, MGRS. A lot of our fellows have got. So what I'm trying to say is there's a lot of opportunity to do case reports, presentations with these. This is still a hot topic with our checkpoint experts, Dr. Sossman, Dr. Chandra, Dr. Young, who are from melanoma and Nolswell. So they are representative of each group. Each oncology group has about 5, 6 oncologists, myeloma group, small cell lung cancer group. And they kind of, there is a point person, I talk to them. We've done some collaborative, very nice, actually, post-transplant melanoma um, research on that in collaboration with John Hopkins. I work with Dr. Dikshit to support him with high-dose methotrexate issues, Dr. Reem Karamali with lymphoma. And these in the bottom is how these has led to some case reports with the fellows and abstracts. Not to leave behind hematologists. We get a lot of their help. Dr. Zachariah, Dr. Stein, Dr. Brady Stein, Regina Stein, they have helped us a lot. They helped me actually in particular to study and go to the new drug testing committee at Northwestern to advocate for doing genetic testing for complement mediated TMAs. They have helped me to identify and give, which is not easily available, ecluximab or the complement inhibitor therapies. So, and those have made a huge impact on patient care. So thank you for your attention.